Hello and welcome, everybody. My name is Angela Taylor, and I'm LBDA's Director of Programs and your host for today's event. Our topic for the day, the updated diagnostic criteria and management of Lewy body dementia. We welcome those who are attending an LBDA event for the first time, especially any clinicians and researchers who learned about it through our co-sponsor, ALS Forum. ALS Forum is a news website and information resource dedicated to helping researchers accelerate discovery and advance development of diagnostics and treatments for Alzheimer's disease and related disorders. Before we get started, here are a few housekeeping items. All attendee lines are muted. Today's webinar is being recorded and will be available for on-demand viewing as well, and you'll be receiving a link to the recording later today by email. Our presentations will be followed by a moderated discussion, so please feel free to submit any questions that you have throughout using the Q&A option at the bottom of your screen. We'll address as many of your questions as possible in the time allotted after the presentations. And I am delighted to be joined today by Gabrielle Strobel, the Executive Editor of ALS Forum, who will be serving as our moderator today. She attended and reported on the 2015 International DLB Conference on behalf of ALS Forum, where she oversees the editorial operations. So thank you and welcome, Gabrielle.
Thank you, Angela. And hello and welcome to the presenters and to our audience around the world. I am pleased to work with the LBDA to help moderate today's conversation after Drs. McKeith and Taylor have presented. I'm also really delighted that we have two leading DLB experts from Newcastle University in the UK for a conversation that's available globally on the topic of dementia with Lewy bodies. As an editor in the field of neurodegeneration research, it continues to surprise me that this disease, which is common, truly terrible for the affected person and their care partners, even today remains quite understudied and often missed by doctors. The new diagnostic criteria hopefully will help with that. As to our speakers, Ian McKeith is a professor of old age psychiatry at Newcastle University. His dementia research career has included clinical pathological brain banking studies, population-based epidemiology, biomarker development, and clinical trials. His current program, based in the Newcastle Biomedical Research Center in age-related diseases, has a focus on diagnostics and therapeutics for Lewy body dementia. And Dr. McKeith is credited with really having pulled together the worldwide effort to articulate a consensus diagnosis for this disease since the mid-1990s. He also led multiple iterations to improve the criteria as the field has been accruing new knowledge. John Paul Taylor is a senior clinical lecturer and honorary consultant at Newcastle University and Northumberland Tyne and Ware NHS Foundation Trust. His research focuses on the application of neuroimaging and neurophysiological approaches in understanding symptom etiology in dementia with Lewy bodies and Parkinson's disease dementia. This includes, for example, research on brain atrophy and brain connectivity and other aspects of this complex, multifaceted disease. Without further ado then, let's get started. Ian, I'll pass the microphone on to you.
Okay, thank you, Gabrielle, and thank you for those nice introductions, and welcome to everybody who's attending this webinar. It's a great opportunity for us to give you some new information about Lewy body dementia. I'm going to start by speaking about diagnostic criteria, and then John Paul is going to follow me by talking about management options. So we could have the first slide, please. Okay, these are my declarations, none of which I think represent any conflicts for this particular presentation. Next slide. Lewy body dementia, as Gabrielle's already said, is common, and if you look at the box on the left-hand side, you'll see it refers to really two conditions: dementia with Lewy bodies and Parkinson's disease dementia, two related dementing disorders. They in themselves fall within a broader spectrum of Lewy body disorders, but today I'm going to be focusing almost exclusively on dementia with Lewy bodies, DLB. which, if you then move to the center of the screen and look at the large red box, if that represents 100% of all dementias in older people, then the pathology of dementia with Lewy bodies, the little box on the top right-hand corner, which shows Lewy neurites and Lewy bodies stained with alpha-synuclein, the percentage of cases that neuropathology studies suggest should be due to this kind of dementia is about 12.5%, the area in blue. However, if one goes into the clinic and into specialist clinics like my own, secondary tertiary referral clinics, only about 7.5% of people with dementia get a dementia with Lewy body diagnosis. So we're probably diagnosing just over half of all the cases that are out there. If you then go the lighter green box into the more general community population, then only 4% of people with dementia receive a DLB diagnosis. So only about 1 case in 3 is being diagnosed. Next slide. So the system by which we make these diagnoses, and have done for the last decade or more, are a set of criteria that we published in 2005. And most people on this call, I think, will be familiar with these. So very quickly, just to say that clinically, the disorder is defined by a particular kind of dementia syndrome with attentional and executive dysfunction and visuospatial problems. By core features, which we have described for a long time as fluctuating cognitive impairment, visual hallucinations, and Parkinsonism. And then a range of other features, which are rather mixed in the sense that some were clinical symptoms like REM sleep behavior disorder. I'll say a little more about that. Particular kind of response to neuroleptic medication or findings on brain imaging. So these were the criteria we've been using. In the box on the right, just to say that these criteria were an improvement on a previous set, and they were an improvement. They increased the number of cases that were being detected by about 25%, particularly in community samples. Next slide. But if one looks overall at the strengths and weaknesses of what we've had for the last decade, well, the strengths on the left are that these criteria were fairly specific. If you had that syndrome of particular dementia type with the core features, then the likelihood of you having Lewy body pathology at autopsy was about 90% high. The criteria were fairly brief and easily memorable, which is important for use in the clinic, and they were very widely used. These are the diagnostic criteria that have been used globally. On the right-hand side, however, are the weaknesses that, although they're very specific, there's the limited sensitivity that 1 or 2 cases out of 3 are being missed with them. Some of the items, like fluctuation is a good example, were said to be inadequately defined for non-experts to use. There's this mixing of clinical features and biomarkers, making it a little bit more difficult to operationalize the criteria. And lastly, and not least, they were 10 years old, so clearly things had moved on a bit. So next slide. We decided to review these and to start a process of deciding whether change and improvements should be made. So I'll not read all of the information here, but just to say that this was a process that started more than 2 years ago, actually, but that culminated in a meeting in December 2015, initiated by our Lewy Body Dementia Consortium and the LBDA. And you can see it was an interdisciplinary meeting, including patient and care partner involvement. So our guiding principles are very simple ones, that the diagnostic criteria that we generated needed to be understandable for generalists as well as specialists. I think that's important if we're going to increase detection rates more generally. We felt we needed a structure that better distinguished the clinical features from the biomarker features, but we thought we should only make changes if there was sufficient evidence of adequate diagnostic sensitivity and specificity. We thought we shouldn't fix what wasn't broken. So if people are interested to see more about this, the abstracts of the meeting were in the journal in green on the left bottom of the screen, and our facilitator today, Gabrielle, wrote an excellent series of Alzheimer's reviews of the meeting, which again are still available to look at. Next slide. So this is our basic product in its simplest form, 2 tables, which can be viewed in a paper which is open access. That means that anybody can open, read it, and download it for their own use. In the journal Neurology, the July the 4th edition this year. And I'll talk mainly about the table on the left, which is the revised clinical diagnostic criteria. I'll not talk now, but I will make reference to the fact that we also, the table on the right, reviewed the neuropathological assessment methods for diagnosing the disorder. So in very brief, we've extended those. We've made some recommendations about increasing the level of neuropathology diagnostic assessment, and we've already started trying to validate that in a global study with 25 centres, all looking at brain sections and scoring according to this new system. But going back to the clinical diagnostic criteria on the left, I'd firstly say that I hope it's still brief and memorable. It may not look brief to some people, but compared with most clinical guidelines and diagnostic guidelines, this remains quite brief. And the basic structure hasn't altered compared with previously. So we've tried not to mend what wasn't broken. But within there is quite a substantial amount of change. We have, for example, separated clinical features out from biomarkers, and I'll talk through that. And try to be much clearer in the text of the paper, which you need to read and look at exactly how these things are defined. So next slide. Here's the first part of the criteria, which describes the nature of dementia in dementia with Lewy bodies. It's now consistent with the NIA Alzheimer's Association definition of dementia, but adds various caveats, such as that memory impairment may not necessarily occur early in DLB, and as before, there are deficits on tests for attention, executive function, and visio-perceptual ability. And in the paper, we lay out the principles of what kind of test and test batteries are appropriate to assess that. Secondly, we describe, again, core clinical features, and these core means that they carry diagnostic weight. They're important in making a diagnosis. 3 are familiar from previously. REM sleep behavior disorder has been added. This is sleep disorder in which, although there is rapid eye movement, dreaming sleep, there isn't muscle paralysis as normally happens, so the person acts out their dreams and shouts and punches and kicks in the bed, and this is a very characteristic symptom of Lewy body disorders, including dementia with Lewy bodies. With respect to Parkinsonism, we've aligned ourselves with the New Movement Disorder Society diagnostic criteria for Parkinson's disease. So we use their system for defining Parkinsonism, but you need less Parkinsonism for DLB than you do for Parkinson's disease itself. Any one of these cardinal features will suffice. Next item. The next part of the criteria is to list what we've called supportive clinical features. These don't carry diagnostic weights or points, but they're like signposts, red flags that alert a clinician that this might be the diagnosis, particularly if there are several of them. And we've indicated here on the slide just which of these supportive items are new. And again, in the text, we describe some of these in significant amount of detail. You'll see that neuroleptic sensitivity to antipsychotic agents, which was previously had a diagnostic weighting, is now simply a supportive feature. And that's because, perhaps as a byproduct of knowledge and awareness of DLB, use of antipsychotics is much less common than it used to be. Next slide. We then move to the biomarker section, and with biomarkers, much as we have core and supportive clinical features, we have indicative and supportive biomarkers. And indicative biomarkers, of which there are 3, are the ones that carry diagnostic weight. So on the top left is the first of these, which is evidence of reduced dopamine transporter uptake in the striatum. So this is FP-SIT single photon emission imaging. The DLB cases in the middle showing a marked reduction in uptake compared with an Alzheimer's patient on the left and a normal control on the right. And you remember that I said that we would only make changes if there's sufficient evidence of adequate diagnostic sensitivity and specificity. And by that, we felt in the consortium about 80% or more sensitivity and specificity was adequate for this purpose. So this dopamine transporter test performs with about 80% sensitivity, 90% specificity. Below is a different kind of imaging modality. This is cardiac imaging, maybe slightly surprising for a dementing disorder, but MIBG, cardiac scintigraphy. This shows loss in the middle image, a DLB patient, of the sympathetic cardiac plexus on the right upper side of the picture, compared with Alzheimer's normal controls. Again, this achieves 80%, 95% specificity and passes the test, and it's been particularly pioneered by our Japanese colleagues. And then finally, on the right-hand side is the third indicative biomarker. This is polysomnography, confirming REM sleep behavior disorder. In the top box with the green arrows, it shows that when there's a lot of rapid eye movement in the upper leads, there's muscle atonia and no muscle limb movement where the green arrows are, as opposed to REM sleep behavior disorder, the bottom screen, where rapid eye movement in the top leads is accompanied by a lot of violent limb movement in the lower leads. And again, this is highly specific, greater than 90%. So these 3 tests measuring very different things. So we have a strong set of biomarkers available to us. Next slide. In supportive biomarkers, so these are ones that either this isn't quite enough evidence yet to use them as indicative biomarkers, or the sensitivity and specificity not quite there. In the top box, very quickly, medial temporal lobe atrophy is often absent in DLB. It looks rather like a control rather than an Alzheimer's case, but it just hits the sort of 65% sensitivity and specificity. It's very useful clinically, but we decided not to use it as an indicative biomarker. The box below, FDG PET perfusion, showing occipital hypoperfusion, the blue arrows at the back of the DLB brain, with preservation of the posterior cingulate in the bottom box, little yellow arrow, the posterior, the cingulate island sign. And then lastly, on the right-hand side is emerging evidence about electroencephalography, EEG, with slow wave EEG activity with periodic fluctuations, may be highly specific, and yet there's limited evidence about this yet. So we didn't really feel at the moment we need more evidence before this again joins the list of indicative biomarkers. Next slide. We're nearly through with these diagnostic criteria. Again, we tried to keep things pretty much as they've been before. So probable DLB is diagnosed with combination of clinical features or indicative biomarkers. Possible DLB is diagnosed either with biomarkers or clinical features. You only need one of either. Probable dementia with Lewy bodies can't be diagnosed on the basis of biomarkers alone. So last slide. In this very quick run through, what I've said is that new diagnostic criteria for DLB have been published recently, which more clearly identify core clinical features and indicative biomarkers. And this is how we will now make diagnoses. We have to prospectively validate these against autopsy, and that work will have already started. Issues still under debate and discussion are the overlap syndromes and the boundary conflicts. So that includes the debate about dementia with Lewy bodies and Parkinson's disease dementia and how they are distinguished from each other. And then secondly, how the Alzheimer pathology that's often seen should be viewed, and especially in relation to what's being called Lewy body variant of Alzheimer's disease. And then finally, we are aware of the interest in early diagnosis, even earlier diagnosis, so prodromal DLB criteria are now also under construction. So thanks for that very quick run through. I think Dr. Taylor is now going to speak to us about management.
Thanks very much for that, Ian. So handing over to me, I'm going to be speaking with regard to the management of DLB. I'm focusing the talk primarily in and around the management consensus information which was provided within the report. So I'm just looking at the slides. Next slide, please. And next one, please. So just my declarations, there's no conflicts of interest in connection with this presentation. Next slide, please. So, as alluded to by Ian, dementia with Lewy bodies, or DLB, is a complex multi-system disease, and we have domains which are affected, such as cognition with cognitive fluctuations. We also have psychosis, including visual hallucinations, delusions, misidentification phenomena, to name but a few, as well as neuropsychiatric symptoms such as depression, anxiety, apathy. Patients also express variable Parkinsonism, autonomic dysfunction ranging from orthostatic hypotension, urinary dysfunction, constipation, and they express a range of sleep difficulties. As you've heard from Ian, REM sleep behavior disorder is the prototypical feature of sleep disturbance, but also patients suffer from insomnia and experience excessive daytime somnolence. All of this can make the management quite challenging, and on top of that, patients with DLB express these symptoms in a wide variety of ways, some more than others, so it's very heterogeneous. However, there are a number of practical measures that we can take. I think the first and most important thing is that, as Ian's indicated, that we get an accurate diagnosis of DLB. From that, therefore, follows an appropriate management strategy. The next important point is that we need to support care providers. Supporting caregivers and families is extremely important. They're our strongest ally when we are making decisions with regard to management. Working through the signs and symptoms of checklists can be helpful. Often patients and families don't recognize that things such as constipation is actually related to the DLB condition, for example. Related to that, education and engagement are vital. There's a clear information knowledge gap for a lot of families and people with DLB. Resources such as the LBDA can be very beneficial for people and help signpost them to further information sources. And finally, most importantly, given the wide array of symptoms, it's important that we take a MDT, a team approach. For example, physios may be helpful for dealing with the motor symptoms, the gait dysfunction, occupational therapists for home adaptations, geriatricians for age-related comorbidities, psychiatrists for behavioral and psychiatric issues. Next slide, please. Now, another challenge that we face is that some of the medications that we give, such as dopaminergic medications, can have a negative effect on cognition and behavior and exacerbate psychosis. Often there's quite a lot of tensions between treating one symptom and worsening another. This is clearly an issue in DLB, and often we have to have frank discussions with people with DLB and their families about these tensions and optimize treatment according to their particular needs. For example, it might be better that one person doesn't have any distressing hallucinations at the price that their motor function is not so good. Another person might prefer to tolerate intermittent hallucinations to maintain mobility. Another issue which is coming to the fore at the moment is the issue of anticholinergic medications. We know that anticholinergics can have a negative effect across the dementia piece in terms of cognition, and in particular in DLB, we know that they have profound cholinergic deficits. In that context, they are probably much more sensitive to anticholinergic medications. Therefore, it's appropriate that we carefully review all medications people are taking in terms of a potential anticholinergic burden. And remember, of course, that medications often have a small anticholinergic effect, but additively, this can lead to quite a significant anticholinergic burden. So rationalizing medications is another important aspect of our job in management of DLB. Next slide, please. So taking a symptom-led approach is important and helpful. Treatments can be pharmacological and non-pharmacological. And we both have an evidence base and also expert consensus opinion to guide us. And I'll touch more upon that later. Next slide, please. With regard to non-pharmacological interventions, most of the work has been in Alzheimer's disease and Parkinson's rather than DLB. Interventions can be patient or caregiver focused or both, and we do have preliminary evidence, for example, that exercise and gait training might be beneficial for motor symptoms and offer some cognitive benefits. Similarly, cognitive training, there's some preliminary evidence to support the use of this. And as I've alluded to earlier, caregiver education and training is clearly very important and may help with the management of psychiatric and behavioral symptoms. There's also some emerging evidence for thickening of fluids for swallowing difficulties if patients experience these. Next slide, please. In terms of pharmacological evidence, there's been a number of quite detailed systematic reviews and meta-analyses in the DLB space. And there's clear class 1 evidence for cholinesterase inhibitors, in particular rivastigmine and donepezil. And we note that there's benefits in DLB for cognition, global function, activities of living. And even if patients don't improve with cholinesterase inhibitors, they're less likely to deteriorate when taking them. Next slide, please. So this is just an example of some of the evidence base taken from Chris Stinton's work and his meta-analyses and systematic review. And this box plot really sort of shows the clinical global impression of change, scale score change from baseline. And this particular meta-analysis combined both the DLB patients as well as studies which have Parkinson's disease with dementia, looking at rivastigmine and donepezil. And if you take a look at this small diamond just at the bottom, we can see that overall there is an overall benefit to cholinesterase inhibitors for improving global levels of function. Next slide, please. Even if people don't respond, again, there's evidence to support the fact that they don't necessarily deteriorate. Next slide. And again, just an example of a meta-analysis looking at cognition, in this case, the mini mental state examination across a number of different randomized controlled trials. And again, the evidence favors the use of cholinesterase inhibitors in DLB. Next slide, please. Okay, what about memantine? Well, the evidence for memantine is less clear. There's been 2 major randomized controlled trials in this space, which demonstrated differences in efficacy in terms of domains which appear to be improved, whether that was cognition, neuropsychiatric symptoms. And also there was a question of whether it helped people more with DLB or with Parkinson's disease with dementia. However, one thing which emerged from these trials is that that memantine was well tolerated. And certainly there's a consensus opinion now that memantine could be used as an alternative to cholinesterase inhibitors, for example, in those patients who may not tolerate a cholinesterase inhibitor, or indeed as an adjunctive to a cholinesterase inhibitor. And certainly there's building evidence from the Alzheimer's disease world that co-prescription of cholinesterase inhibitors and memantine might have benefits in moderate to severe disease, although we don't really have that evidence base as yet in DLB. Next slide, please. So perhaps you're getting a hint of where I'm going with a lot of what I'm describing. On one side, there is some evidence. We're clearly on-piste. It's nice, clear slopes, clear evidence. But unfortunately, a lot of the symptoms we have to rely on expert opinion and go off-piste. Next slide, please. Now, when we look at cholinesterase inhibitors and potentially their impact on other symptom domains, there's certainly a suggestion that they might help with neuropsychiatric symptoms. However, when you take a look at the trials which have included neuropsychiatric symptom scores, they're often the scores are aggregated, so it's hard to see if there's a benefit on a specific domain. Although certainly maybe donepezil might help with delusions and hallucinations and possibly apathy. Next slide. Now, we've heard from Ian that certainly antipsychotics are best avoided given neuroleptic sensitivity and increased mortality in DLB. However, if they are required, certainly the possible use of low-dose quetiapine and clozapine might be options. Now, the actual trial evidence within DLB for these agents is very, very limited. Certainly, evidence from case series does exist for quetiapine, but trial data has been negative, although the sample sizes in any RCTs has been small. Clozapine has an evidence base in Parkinson's psychosis, but it's less clear whether it would be beneficial in DLB, and certainly its use is often precluded by the fact of its side effects. So antipsychotics remain a difficult area in DLB. Next slide, please. However, there might be some hope. Many of you may have heard of the new agent pimavaricin. There's no evidence as yet for its efficacy in DLB, but there is certainly an evidence base within Parkinson's disease psychosis. And the major trial which examined this particular agent certainly included people with Parkinson's disease who had cognitive impairment. Improvements were noted in neuropsychiatric symptoms as well as sleep, and most importantly, it appeared to be well tolerated. Next slide, please. Now, antidepressants, we have very limited data in DLB, and therefore the best approach is probably to consider your own clinical judgment of what is most appropriate, i.e. what you would use in other dementias, whether that would be an SSRI, an SNRI, or mirtazapine as appropriate. Next slide, please. Now, certainly the Parkinsonism may improve in DLB patients, certainly in some DLB patients. So it is worth considering this agent where there is a particular motor deficit which needs treating. This, of course, needs to be balanced with the increased risk of psychosis, but I think it's perhaps we tend to underuse our levodopa in our DLB patients. So it's something to be aware of, particularly if the hallucinations are under control and there is no specific behavioral symptoms that you're concerned about. Next slide. More practically, we need to think about falls. DLB patients are very prone to falls. Safety assessments, physiotherapy input are all potentially beneficial. Having a good geriatrician, doing osteoporotic screening for bone mineral density or vitamin D status is important. Next slide. For other symptoms, we have to draw upon evidence base in similar diseases. For example, the use of clonazepam or melatonin for idiopathic REM sleep behavior disorder. Translating that across to DLB, certainly these agents do potentially work for the RBD. There is a tendency for melatonin to be used first line given its low side effect profile in comparison to clonazepam. In treating autonomic symptoms, fludrocortisone might be beneficial, for example, for orthostatic hypotension. Next slide, please. So DLB is a complex disease, but I think importantly, complexity should not equate with treatment nihilism. We've got a very clear evidence base for cholinesterase inhibitors and possibly memantine. Taking a system-based approach in collaboration with the patient and families can be a very effective approach. Next slide, please. I think we can look to the future with optimism. There's huge pharma interest now in DLB with many new trials. This is just an example of some, taking a look at 5-HT6 antagonists to boost cholinergic function, or 5-HT2A receptor inverse agonists to treat psychosis or sleep dysfunction. But we do need larger efforts in this space, first of all, to define better clinical trial outcomes, to improve our clinical trial design, how we can stratify our patients better, perhaps using some of those biomarkers that Ian has indicated, getting larger sample sizes and working together, as well as dealing with the confounding factors which trouble a lot of DLB trials, such as the cognitive fluctuations and use of concurrent medications. Furthermore, we need to consider trials right across the severity spectrum, from prodromal to end of life. Next slide, please. And this is just an example of a pragmatic approach which we're taking here in the United Kingdom. We have a study called the Diamond-Lewy study, which is combining expert opinion with the evidence base and systematic reviews, as well as public patient involvement to develop a practical management toolkit which can help people with dementia with Lewy bodies and Parkinson's disease dementia And we're hoping that this will be available in 2018, early 2019 for use internationally. Next slide, please. I think that's it. Thank you.
So thank you very much, Dr. McKeith and Dr. Taylor, for these presentations. There's lots of material we can discuss. Maybe we could start just with a look back to the few months since the criteria have been published. They were published in July 2017. So Dr. McKeith, what has the response been among clinicians in the UK and internationally? What's been the uptake? Have you noticed that they're used, they're replacing the old ones? What are people saying?
Okay, well, I'd like to say yes, of course, but I think it takes a little bit of time producing guidelines and implementing them. I think people know that there's a time lag, but the general response has been positive. I think people have seen these as improvements, achieving some of our goals of clarification and trying to make these more accessible to a wider group of diagnosticians. So, but I think in terms of measurable, outcomes and data, it'll be a year or something of that kind before you can actually measure data on that. But the initial response has been very positive, yes. And interestingly, I've had a few contacts from families who've said that their loved one has had a diagnosis of DLB made in the last few months because the new criteria were out. Some clinicians had seen these and their awareness had been prompted by that having happened.
Oh, very good, very good.
Yeah.
You spoke about the 2005 guidelines having been quite specific, but they weren't sensitive enough. So if you had to choose a single feature in those new guidelines, which one do you think increases sensitivity and maybe clinician awareness the most? Is there one that stands out?
No, and I think that's why guidelines exist, because no one feature by itself is sufficient. I think you could make an argument that REM sleep behavior disorder is a very highly specific marker of Lewy body disease, and this may happen 10 or 15 years before any cognitive or psychiatric symptoms occur. However, diagnosing REM sleep behavior disorder isn't entirely straightforward. Sleep disorder specialists will tell you that. So I think it's the combination that's critical. And of course, it's very dangerous sometimes that people will self-diagnose on the basis of one symptom. And Parkinsonism is another quite good one. Somebody who's got some cognitive impairment and they have something they think is Parkinsonism, and it's actually not. It's a movement problem of a different kind or a tremor of a different kind. So ultimately, this is expert evaluation using a complex but not too complicated system.
Right, yeah. That's maybe part of the crux here, that you want the features of the disease to be simple for really many clinicians throughout to associate that in their mind with the disease. But on the other hand, the disease is multifaceted, complex, so it's really necessary to be steeped in all the different features that are part of the criteria.
Yeah, I think DLB has quite a reputation for being a difficult diagnosis. And actually, when you see it in its typical form, it's really quite an easy diagnosis. As I said, the specificity is high. There's some very characteristic symptoms, features. The difficulty comes with the cases that aren't typical. And that's really, I think, what we're now trying to chase a bit more, especially with the biomarkers.
Right, right. I looked over the news article that we wrote on Alts Forum when the criteria came out, and I noticed a commentary that came in from your colleague and dementia clinician, Cristina Muscio from Italy. She wrote about a hierarchy of the core clinical features. She suggested a ranking in specificity as REM behavior disorder, visual hallucinations, fluctuations, Parkinsonism, and she asked if they should or could be weighted accordingly, you know, where RBD alone could maybe warrant a diagnosis of probable DLB in the presence of dementia, but Parkinson's would not. Do you agree with that? Do you think they're all equal, or could they be weighted? Again, to try to simplify.
Well, I think several of us have tried to devise weighting systems rather unsuccessfully. And in the new criteria, dementia with REM sleep behavior disorder supported by polysomnography is probable DLB, and also Parkinsonism with an abnormal DAT scan would be DLB. And I agree there probably is a nuanced difference between RBD, dementia and RBD with abnormal polysomnography maybe is more likely to be Lewy body dementia than Parkinsonism with an abnormal DAT scan. And I think we'd always encourage clinicians to sort of triangulate and look for further evidence, outside of that small box, by which I mean, so with dementia and Parkinsonism and an abnormal DAT scan, you would really look hard for REM sleep behavior disorder. You'd look for evidence of cognitive fluctuation. I think, guidelines are at the end of the day exactly that, guidelines, and the clinician really has to then do a bit of detective work and hunting with them. I think simply to make it into a hierarchy is to oversimplify.
Well, I think there's a lot there maybe in terms of how much guidance the guidelines can actually provide, especially in chasing the more unusual presentations, as you said. I remember, for example, there was a question also after our news coverage, if the criteria could give some specific examples of which supportive biomarker assessment would be most informative for given patients. For example, if the core clinical feature is Parkinsonism, a clinician might not order a DAT scan, which you would assume to be positive, but instead order an cardiac MIBG scan or an FDG PET scan, because those would interrogate something the clinician does not already have a hunch about from the clinical exam. So, and I think that to me just reflects, again, how complex it is when you look at all these different categories of core, supportive, indicative. And so I'm wondering, do you think flow charts of what sorts of tests a clinician might want to order based on what a patient presented with clinically would help, more clinicians out there who see DLB much less often than you and Dr. Taylor do? Would that be feasible to spread the use of these?
Yeah, I think that's a very valuable suggestion. And we did talk about that at the consortium meeting, and I think we would have liked to have that level of detail in the paper. But of course, with a 4,000 word limit, there becomes, that's almost for the next time. But I agree with you. I think that we might usefully supplement this with guides or, as you say, diagrams or flow charts that suggest ways that people might go about applying these. However, there are so many permutations, really. So I suppose one hopes that most clinicians will try and use these in an informed and sort of curiosity-driven kind of way, doing exactly what you said, that if they have a person with dementia and Parkinsonism, then that they might look for evidence elsewhere, and do an MRBG scan or polysomnography. Yeah, I agree with you completely. And that's a little bit what we're doing in the, remember Dr. Taylor's last slide almost was about the Diamond Lewy project in the UK, doing a diagnosis and assessment toolkit. And that's the kind of level of advice we'd hopefully try and get into that.
That'll be great also to have that be so widely available. Since you mentioned the MIBG cardiac test, we have another question here from the audience. So, how widely available is that test, and has its inclusion in the new diagnostic criteria as an indicative marker helped expand its use for the diagnosis of DLB?
I don't know if Dr. Taylor wants to answer that one, or I mean, I'm willing to start. I think that it's theoretically it's widely available because this is a test that's been used by cardiologists for many years. So, it may be a certain amount of technical adaptations and threshold for reporting's slightly different, but in essence, the test is available, the equipment's available, the ligand's available. So it's really more a matter of patterns of use. So, and of course reimbursement kind of issues. But there are no significant technical reasons why this shouldn't be widely used. Is it being used yet? I think that centres like ours are now beginning to use and evaluate it. I think I said in the talk that in the presentation that Japanese clinicians have been using this really for quite a long time. I know several European countries have been using it for the last 5 years or so, and I think it will become much more widespread.
As I recall, in Japan, it's formally approved for the diagnosis and also reimbursed countrywide. So maybe the challenge really is locally in many other countries to raise awareness.
As in Japan, our cholinesterase inhibitors or donepezil is approved for treatment of patients. Yeah.
Right. Yes, they're really ahead.
And of course, they've been absolute pioneers in this field.
We have some questions. We have a question about the neuropathology as part of the diagnostic criteria. Did the pathologic criteria change? And is the table of high likelihood, intermediate likelihood, and low likelihood the same still?
No, the criteria haven't changed as yet in that way. We simply made recommendations, as I said, about ways that pathological findings should be assessed, and we're now in the process of evaluating those. So there is no change at the moment. Table, just to clarify for people, the high likelihood, intermediate likelihood, and low likelihood are the likelihood that a person will meet the clinical diagnostic criteria depending on what distribution of pathology they have in the brain. And it's a distribution not only of Lewy body pathology, but also of Alzheimer type pathology, because the two things have an impact on it. So for the time being, the categories that we've added of Lewy body pathology are basically ones that we think are low likelihood of having a DLB kind of clinical presentation. And that's important because in a strange way, they're the kind of cases that in future we need to identify the ones that don't look typical. You know, what I've said to you is that the criteria that we've had, and hopefully the ones that we've got, are now a bit better at identifying typical cases. But in future, we need to move a bit more to looking at these lower likelihood of typical DLB. And that, of course, includes the prodromal and early cases. So we're really trying to extend the neuropath assessment to eventually be more sensitive and broader in its targeting.
We have a few questions about clinical trials. First, perhaps the clinical trials that are being done in a DLB, and current ones are just, I think, maybe a handful. Which criteria are they using for inclusion? Have they already adopted the new ones? Are they using any biomarkers that are part of the new criteria? Or is all of this clinical trials work still happening with the 2005 criteria at the moment? This might be a question
inevitably, given that the new criteria... Oh, okay.
Yeah, Ian, you go ahead. You've started, I think.
You sure?
Yeah,
inevitably, because the criteria were only in the public domain in July of this year, any trials that have been recruiting until now have been using the previous 2005 criteria. But that's not problematic. You know, we've constructed. I've always said that this is a process of evolution, not revolution. So we haven't changed diagnoses that would have been DLB previously aren't going to turn into non-DLB diagnoses. That isn't the intention. The idea is to make more and more accurate DLB diagnosis in future. So old studies, or the one or two studies that have been in progress, have used the previous criteria. I imagine any new trials will move to the new criteria.
We have a question specifically on pimavanserin. So its sponsor, Acadia, recently announced a phase 3 study of that drug with dementia-related psychosis, and the FDA in the US has granted breakthrough therapy designation. Now, given the success for psychosis and Parkinson's with this drug, are you optimistic about its use for DLB?
Yeah, I mean, I'd certainly, I mean, again, that's mirroring activity here in the UK, where it's been trialed for psychosis in Alzheimer's disease. And certainly, you know, if you go on first principle basis, the sort of serotonergic effect of on the brain, potentially, you know, changing that to ameliorate psychosis. It's got good evidence in PD psychosis, particularly with the hallucinations and delusions. So you could see this translating across. I think it's really just persuading folks that we need to do a trial to see that it's actually a viable agent. And of course, there is the Axavant study, which is using a similar agent, which is ongoing at the moment within DOB patients. So I think we've definitely got watch this space with these particular types of agents targeting the serotonergic system.
Study failed quite spectacularly and often.
Yeah, but this is a different one. This is not there. This is that's the one which is the sort of the RVT 101, which was in the Alzheimer's. So they've got the separate one, which is very much taking a look at nilotanserin, which is, you know, similar to pimavanserin and in the sort of some of the attributes and the receptor effects. So again, you know, it may be that, you know, the RVT 101 is not successful in terms of boosting cholinergic function, but maybe their other agent does have a beneficial effect in terms of psychosis or other domains indeed. So I think.
Do you know if any biomarker work is likely to be included perhaps in the nilotanserin trial?
Well, Ian, you've had a bit more involvement with that trial. I don't believe there is any biomarker work.
I think I mean, I think that at the moment that they're interested to see which might be the treatment responsive symptoms, whether it would be the psychosis or whether it might be the REM sleep behavior disorder. So you can imagine stratifying patients, you know, according to those polysomnography abnormal or not. But I think the simple answer is no. At the moment, these are fairly early phase exploratory studies.
I mean, I think the other important point, sorry, I was just going to say the other important point, again, coming back to one of my slides, is that going forward, developing good clinical scales to actually measure things such as visual hallucinations and changes in visual hallucinations is probably sort of a primary sort of concern for us to make sure that that's driven forward, because, you know, we don't want to be doing lots of trials on DOBs and coming up with vague signals, particularly because our measurements instruments aren't really measuring what's important. So I think no doubt about it. I mean, the nilotanserin trial, I think, has been looking at some novel, you know, visual hallucination scales. So I think that's an important move in the right direction.
Yeah, and I think, you know, the word biomarker is a big word, isn't it? So probably what we should say is the indicative biomarkers that I've talked about are biomarkers to distinguish DLB from Alzheimer's disease. That's really what that's shorthand for. And I think that might well be different from a biomarker that predicts response to a particular type of treatment. So what we don't have, for instance, is we don't have a direct biomarker for synuclein or aggregated synuclein, which, you know, you might want if you were going to try and have a biomarker for response to an anti-synuclein agent. So I actually think the best biomarker we have in some ways at the moment is in relation to response to cholinergic agents is probably reaction time on attentional tasks, which is a fairly good surrogate for cholinergic function. So I think, you know, biomarkers can be a misleading word in some ways.
Yeah, certainly the Alzheimer's field, which is far ahead of DLB in terms of clinical trials, has spent years and is still spending years trying to define which markers are useful for inclusion criteria, which markers are useful for predicting progression speed, which ones are useful for measuring drug response. They're all different markers for different purposes, and it takes a lot of research to define those things. Yes. I'd like to ask, since we also have researchers attending, what about genetic testing for GBA? You know that GBA mutations are a strong and common risk factor for DLB, especially in certain populations, and they're linked to earlier onset or to worse alpha-synuclein pathology, and they're tied to lysosomal dysfunction mechanistically. So what would it take? They're not part of the diagnosis right now. So what will have to happen between now and a future time when GBA mutations will have a place in diagnosis, as certain mutations support the diagnosis of certain types of Alzheimer's disease? Why not now? What would have to happen to include GBA in diagnosis?
Well, I think that there have been suggestions that genetic testing should be part of the clinical evaluation of DLB cases, although that certainly wasn't the recommendation of our paper. I'm not an expert on the GBA mutations, but I think for any given individual with one of the many mutations that exist, it's not easily possible to quantify their risk. I mean, you can say that they are at increased risk, but perhaps no more than that. So I think really until they're better characterized would be my view of it.
I mean, I think, certainly the GBA mutations, I think there's quite a high rate, I think about 30-odd% in Ashkenazi Jews. So certain populations will express this a lot more, and it is obviously clear and building evidence that having a GBA mutation alters your clinical phenotype in some way. So I think this is a space which has got a lot of exciting work to sort of develop, and I know a lot of studies are focusing in on individuals who have got GBA mutations specifically, again, because this may offer a slightly different disease-modifying route, as it were, in terms of treatment. So I think it's something which we need to develop, certainly. But of course, the GBA mutation at the moment, from what we understand, is probably making up a minority of individuals with DLB.
An area where we're making progress is finally we're establishing large networks of DLB researchers and research sites to collect large biosamples to answer some of these questions a bit better.
Right. I think we're coming up to the end of the hour really fast here. I will put another audience question to you there. Someone is interested, given the concerns about the antipsychotic sensitivity among people with DLB, do you ever prescribe Seroquel, for example, or Clozaril? Dr. Taylor mentioned 2 other antipsychotics, but maybe the audience would like some clarification of what you do use and what you don't use.
Well, certainly, I mean, Ian may want to chip in here, but quetiapine seems to be the poison of choice, which we tend to use. I think that, again, the case series evidence does support its use I mean, I can only speak from an anecdote perspective that some patients do respond to it reasonably well in low dose, particularly in combination with cholinesterase inhibitors. We in the UK have some challenges in and around using clozapine, mainly because of the sort of practicalities of getting blood tests, and often our sort of dementia services are based in psychiatric hospitals, where getting some of the routine follow-up can be a little bit more tricky for a few of the blood tests and also the monitoring of the dementia patients. But certainly I know a lot of my colleagues, particularly in the sort of Parkinson's clinics where they've got better infrastructures to help support, have been using Clozaril in very low doses with reasonable effect. But again, this tends to be much more on the Parkinson's psychosis to the PD dementia side of things.
Thank you, Dr. Taylor. I will close with one last question that takes a look toward the future. We clearly, the task ahead of us at the present with these new criteria is to get them much more widely used among clinicians internationally for diagnosis, biomarker research, and also get them incorporated into clinical trials. And that's a large task. But on the research side, how long until we have diagnostic criteria for prodromal DLB? I know this is going on and a lot of people are working hard on this, and we're all interested in the early stages of neurodegenerative diseases these days. Would you be able to give us a brief status update on when that might be coming? And with that, we will close the hour.
Yeah, I think that one has to make statements about things like diagnosing prodromal disease very carefully, because clearly it carries a lot of implication for many people, especially in the absence of any preventative treatments at the moment. But it is underway. You're right. The consortium group who met to pull together these criteria are now getting engaged on prodromal criteria. Several groups have published their own ideas about this, which comes to a reasonable degree of agreement and consensus. I think the model that we've got for Alzheimer's disease may not work quite so well for prodromal DLB, because actually in its prodromal stages, it isn't necessarily just a cognitive disorder. It may be a psychiatric disorder. It may be a delirious disorder. It may be a disturbance of consciousness disorder. It's quite protean in its manifestations. So I think that I would hope that by next year, 2018, there are some criteria out there which try and capture all of this. It's not just going to be mild cognitive impairment, DLB. It's going to be a range of prodromes that will be described. So I'm optimistic that that work will get done, and I realise that there is some urgency about it.
Mm-hmm. Mm-hmm. Yes, much work to be done still, for sure. We've reached the end of the hour. I want to thank you, Dr. McKeith and Dr. Taylor, for your time and for your work in this area. Also, Angela and LBDA for putting this up. I will say goodbye and pass the microphone on to Angela for a closing remark. Thank you, everybody.
Thank you, Gabrielle. And to everybody who attended, thank you so much for making the time out of your busy schedules for joining us. All of our webinars are recorded and posted on LBDA's YouTube page, so please watch your email for the link to today's webinar, and we encourage you to please pass it along to others who may find it of interest. Most of LBDA's programs are made possible through donations, so if you'd like to make a gift, please do visit our website, lbda.org, or call our Atlanta office at 404-935-6444. Thank you again for attending our LBD University webinar. We hope you enjoy the rest of your day.